Would like to introduce Dr. Nitin Ambadekar. He's a senior technocrat with experience of more than 25 years in the public health sector with varied experiences in public health, including health services management, public health training, health policy, hospital management, supply chain management, procurement, HR, and the list goes on. He has authored numerous peer-reviewed publications and currently leads several national-level implementation research projects in collaboration with ICMR and other academic institutions. Dr. Sachin Gupta, over to you.
Well, thank you. Thank you so much. I must appreciate and thank Dr. Nitin Ambadekar for actually making his time to attend this kind of conference. And we really missed you in the morning, Dr. Ambadekar. I'm quite certain that his passion and his interest in engaging with the people is quite evident, that despite the fact that he had meeting with the minister and the next week, on Monday, they have assembly session. Despite that, he's made it to be amongst us. So thank you, Dr. Nitin, so much. And I must tell everybody that my association with Dr. Ambadekar goes back to almost 25 years. And we were the first responders, and somebody gave an example of polio eradication in the morning as one of the successful stories. And in 2001, when the whole country was ravaged and had polio as epidemic levels, Dr. Ambadekar worked on behalf of the government of Maharashtra. He was deputed in Eastern UP, and he was based in the district of Maharajganj. And I was his partner in crime in the adjacent district of Azamgarh. And we both actually worked on polio eradication project. And then I moved into my hardcore public health development sector work, but Dr. Nitin Ambadekar has been as part of the system of government of Maharashtra, and today he's the Director of Health Services, government of Maharashtra, and we spoke about maternal, newborn, child health, facilities, communities. You talk about everything that we spoke about, and he's the man, Friday, who actually manages it for the government of Maharashtra. So thank you so much, Dr. Nitin, for being here. He's a man of very few words. He believes more in work and very little of talks. But I'm going to use this opportunity to just, allow him to understand the gathering here. We have academicians, we have researchers, we have development sector partners, we have philanthropic organizations, and everybody's point of discussion is how can they partner, collaborate, as a part of the larger ecology to, advance issues related to maternal, newborn, child health, nutrition, and primarily the whole ecology around it. So, the first question to you, this is just an informal thing because I know he has to rush, so I've asked him for just 5 minutes of his thoughts and maybe your vision on how exactly the government of Maharashtra under your leadership looks at addressing this issue of first 1,000 days, primarily looking at maternal and newborn child health, with partnering with all these institutes or organizations that are in front of you. And do you want to give any special message to them of how can they engage with you or the government to make sure that your projects are scaled up and wherever there is a support required from them can be sought after? And at the end of the day, you're looking at the benefit of the children and the mothers in the state of Maharashtra. So just a few thoughts from you, Dr. Ambadekar, and we know you're short on time. Thanks.
Thank you. In fact, I think I was the part of some panel, but could not come. Suddenly, thrown like something to be spoken about the 1,000 days. Actually, being a part of government, we probably look all this program from that perspective that basically our role is the implementers part. So how to reach every nook and corner and every last mile is important for us. I just listening to adolescent-friendly health clinic about this various issues and challenges. So in fact, we have rolled out this RKSK throughout the state. problem is what we expect out of it is actually to the limited, because maybe a capacity or maybe that type of passion which is required in the field to address such challenges. About this 1000 days or any part of it, practically now what we are thinking of is something like a continuum of care, which is always been thought of and talked much about it. So what we have added, like this adolescent care, and before ANC period, there was not much focus on that period because we are talking about ANC, PNCs, and then the services, reach of service to them is to certain extent limited. So what we have focused our attention on the preconception period. So we have roll out one program. We are training our people to reach to these mothers or in fact couples before conception, and then all this activity of identifying risk factors, counseling them, improving their health, so that whenever they entered into this motherhood or the conception, the mother should be in a good condition. So programs are lot many in the government sector. So basic problem is implementation. So what is the role, like academic institutions or NGOs or developmental partners, those who are coming up? What I have observed is during this tenure, many comes with many ideas. So probably we don't require that many ideas. What has happened is because of all such ideas, there are many verticals which has created in the system. And then they are not talking to each other. Then all ideas come with some need to generate the data. Then monitor on that data. So finally, there are only few people at the grassroots level. If we consider this 1000 days, then this is basically a primary and maximally secondary care level of activity which we require to develop them properly. So there are few workers, some A&M, some MPW. Now we have introduced ASHAs. So sometimes it seems all ASHA is on ASHA to provide the service, without understanding why we have selected the ASHAs. Probably if ASHA would have done counseling, adolescent problems, health, communication, motivating the people to the health system, that would have been a better role for the ASHA. But because of everything, now ASHA has to generate the data, because every program requires data. And if these 3-4 people are there, ASHA, A&M, MPW, both of LHV, medical officer, finally it comes to it. But he also delegate everything to the field person. So what I think is key implementation part. So there are many research ideas, like what you say about the anemia. Still we are 60% people are anemic. Years together we are feeding our population on IFA. And still it is there. So there are no answer as such at present why it is there. So everybody is like coming and telling there was 60% anemia, 70% anemia, सब होना चाहिए. So if you have a proper regimen, everything is there, SOP is there, logistic is there, supply chain is there. So still we are anemic. And still we are talking about anemia. So my issue when I'm looking at the community and then I have to see the indicators where we are progressing, what most I request is how we can implement all these ideas and SOPs in the field. So in that way, if all the academia or developmental partners help us, so probably we will be able to do a better job in that sense. But otherwise, being just on the other part of it, there are so many areas in which we are working. Now we have started working again, breastfeeding part. We are now collaborating with the BPNI on large scale again. What you say is the training or orientation of our workers in the field. Another area where we are working is like collaborating with the ICDS for this growth monitoring part, which is somehow in last few years has been neglected. So we are again putting our emphasis on this breastfeeding, growth monitoring, and in fact, all our like hospitals now started with early initiation of breastfeeding because of repeated practices. Breast crawl is universalized. So activities which is for 1000 day and for the development is needed, that we are prioritizing. Along with we are prioritizing this perinatal health. So that is one of the area we are on the plateau of this neonatal, infant and maternal deaths. So last 3-4 years we are almost stagnant. So again we have started like focusing on this perinatal health, and that's how we also started preconception concept to reduce this low birth weight and congenital anomalies so that we can early identify and reduce further our maternal and child death. So these are some of the areas where we are working. Recently, ICDS has also, it was a long association between health department and ICDS because these are the functionaries working at the grassroots level. And we are further strengthening it now with the uniform, the tracking system, basically. Through NRC, malnourished children, then they're tracking to the ICDS Anganwadis, and then to the hospital, and then back to the community. So with ICDS, with this tracking system, we are trying to establish so that there will be a continuum of care, and then we can follow the progress of the children. So these are some of the activities we are doing. So finally, I just wanted to end here. Thank you for organizers, Dr. Sachin, for so much he said out, but academically I am really poor just because of working in the system. I know the things. So, so thank you very much for patiently. Thank you.
Thank you. I think I won't put him more in the spot because he has to go back. But thanks for your thought. What we kind of infer from you is the challenge is more about implementation because the guidelines and the presence of everyone is there. But at the grassroots level, I think singled out Asha, that's kind of It's just like the last proverbial straw on the camel's back is kind of example is trying to give. So we need to limit on how much we really need to load on Asha and to expect her to be getting the impact what we desire for. Thank you so much, but we really appreciate your time. I understand that there's so much on his mind as well besides what's here. But maybe just one last question. From the implementation point of view, given a choice, you have a well-capacitated human resource at your end, you have data, and you have, let's say, technology available to you. What amongst the three would you choose if you're given only one choice to make sure that the implementation happens at scale and to the levels of impact that you expect? It's a tricky question, but I'm trying to get a one-point answer from you on that.
No, it's not that difficult. In fact, everything which is there is, if we look at the data and work on it, we understand what is the meaning of that data, and then work on it as per the data which tells us the story, what is behind that. So probably we'll able to, in fact, implement, monitor, and progress on so many issues. And that is the key factor which is not available probably. In fact, or maybe we don't have time to look at the data because so many data is generated. To analyze that, we have partnered with IIT also to take the analytic dashboard for that. Now we are working on unified platform at the field level so that only single entry need to be done, and then that will be fetched across all the portals which is required by so many people. That is basically dream. In fact, I was hearing from Jio also for last 10 years, but that has not been materialized. We are just trying, piloting the things. If it is possible, then probably we can use this data effectively. And another issue is to train all this workforce in using the data. That is also very critical because being labeled as an implementer, we stop looking at the data. We are just looking at the data in the monitoring point of view. Like now this maternal mortality is 50, or what you say is the example of anemia. Here so many high-risk severe anemic patient is there. Here so many severe anemic patients are there. We need to reduce, provide the medicine and complete it. But why that is happening? So what is the what inference or what you say the intelligence coming out of data is like an important part of it, and we need to train our people. I'm saying about my people into this. Okay, that is the only critical issue. I think one critical issue which can improve our system. Thank you.
So brilliant. So the holy grail for any sharp scale-up implementation and for any kind of systemic approach, the holy grail is data. The word is out. Unless and until you have quality data and that data coming out informing what needs to be done, because I completely agree with him, the technology are the enablers. They are not the ones which will bring you the data. The technology can capture the data, but data needs to be intentionally captured from the interventions. And when you have the data and the data provides you with whatever gaps that are coming out, then the capacity building, interventions, your strategies, your approaches can be worked out. But everything depends on intelligence, information, and data. Thank you so much for that, Dr. Ambadekar. And I think I'm going to stop here. I really, really appreciate your time coming here. Thanks a lot.
Thank you so much, sir. Thank you so much. And I request Mr. Karan Kapoor, please, if you can present Dr. Ambadekar a token of appreciation. Mr. Karan Kapoor is the director of K-Corp Charitable Foundation. Thank you so much.